This podcast is brought to you by the Pacific Neuroscience Institute Foundation. Are you looking to support your memory and optimize your quality of life? Develop a healthy brain for brighter days at PNI's Lifestyle Program, available virtually and in person. Reserve your spot today. Visit pacificlifestyle.org to learn more.
Hello, this is Anthony Effinger. I'm the host of the Think Neuro podcast at Pacific Neuroscience Institute. And today I'm talking with Dr. Courtney Volker. She's a neuro-otologist at PNI, and she's going to tell us what that is. And she's going to tell us about cochlear implants, among other things. Dr. Volker, thanks for joining us.
Thank you for having me. So I'm very excited to be on this Think Neuro podcast.
Okay, so first things first, neuro-otology. What is it?
So neuro-otology is a subspecialty of otolaryngology, which is a fancy name for ear, nose, and throat surgery. And a neuro-otologist does a regular training in ear, nose, and throat surgery, and then extra 2 years focusing on the lateral skull base and the ear.
Okay, so you add on to the base there.
Yes.
Base studies. This is going to sound a little strange, but what unites the ear, nose, and throat as a specialty? I can sort of guess, but those are always grouped.
Yeah, so it's basically historical in the fact that, anything in the head and neck were lumped together, and the pathophysiology and disease processes of the ear, nose, and throat, they all sort of meet in the back of the nasopharynx. And so by learning the anatomy in that area and following the disease pathway sort of broke off ear, nose, and throat as a specialty.
The nasopharynx, what is that?
That's in the back of the nose and throat where they meet.
Okay. So that's sort of, okay. So tell us how you chose a specialty.
Well, I was always fascinated with the complex anatomy of the head and neck. And then in medical school, when I learned about the cochlear implant, I was really inspired. So the cochlear implant is an implantable surgical device. It's the only device in medicine that we have to restore a peripheral sensation. So we can actually restore hearing in babies who are born with profound hearing loss, or in adults who go on to lose their hearing over time. And we can't do it for vision yet. We can't restore sensations. We can't restore people's function after they're paralyzed from a spinal cord injury, but we can restore hearing. And the brain is an amazing thing. I have a PhD in developmental neurobiology, so I wrote a dissertation on how neurons are born in the brain and how they're affected by the peripheral sensation. And now I'm combining that with my surgical skills of actually implanting cochlear implants in both a pediatric population and the adult population. So that's why I chose the specialty I did.
How neurons are born in the brain, did you say?
When neurons are born in the brain, a big question is, are they genetically programmed for their eventual role in the brain, or is the peripheral sensation peripheral input coming into those neurons, are they helping to program the cell fate? And as it turns out, which is not surprising, it's a combination of both the genetic makeup of a cell as well as the peripheral input coming in.
So it sort of has some adaptability to its stimuli.
Right. So nature and nurture meeting together.
And when you say neurons are born, you're talking about when we're in the womb, or are we talking about?
Right. So when we're in the womb.
Okay. So it's starting there and seeing how, okay. All right. And your PhD is in that.
My PhD is in very basic neurobiology. That's right. And now as a clinician and a surgeon, I get to kind of come full circle, and I am able to work with babies that are just coming out of the womb when they're very little. And then we detect, okay, with the newborn hearing screen, here's a child that is profoundly deaf. And so something went wrong during development in those children. And then also all the way to our twilight years as we get older and hearing aids are no longer working for people. And they're starting to become isolated and with cognitive decline as the hearing loss becomes worse over people's life. So I'm also able to take care of those people as well.
How long have we had cochlear implants? How long has this been a technology?
So cochlear implantation has been around for decades, but each reiteration of the devices become better and better. So the devices become smaller in profile, the external processors, which are the computer pieces, become more advanced as technology advances. So it's really exciting to see how these implants have developed and changed over time. Now you can hook the information up to your telephones, your cell phones with Bluetooth technology. The implants can now connect to loops in public areas, just like hearing aids can. So if you go to a concert or a place of worship, there are oftentimes loops in those public arenas that your hearing aids and your cell phone and your cochlear implants can hook into.
So you're getting on the network.
You're getting on the network
with your cochlear implants.
With your cochlear implant.
Oh,
it's really, really exciting. And to see an older adult that, we now have research to show that hearing loss not only leads to depression, social isolation, anxiety, loss of work, loss of income, effects on the relationships. But we're now learning that it's also affecting cognitive decline. And the really exciting research that we've found recently in the last, 3 to 5 years is that when we measure people with hearing loss, we measure their cognition, meaning their ability to have memory and quick thinking at time 0. And then we treat hearing loss aggressively for as little as 6 months, either with hearing aids or cochlear implants. And then we retest cognition in 6 months, people's cognitive scores go up. And so now this has totally changed the way I practice and counsel patients. I share this information with them where I'm now starting to screen my patients for hearing loss, even though they're not maybe complaining of detectable hearing, so that I can start tracking people and I can intervene quicker.
Yeah, that makes tons of sense, right? It's kind of a use it or lose it on hearing and cognition, right? I mean, you need the input, right?
Right. So, when I was being trained in my fellowship and residency, the idea was, well, let's just wait till the person is really complaining about their hearing. And now we really counsel the patients that let's treat this early. And it makes sense because, if you compare hearing loss to vision, we don't walk around with blurry vision, right? As soon as we detect any kind of vision loss, we fit people with properly fit glasses. And so that people can have clear, crisp vision. Well, why don't we do that for hearing? Why do we wait until people really are struggling in their environment? We need to fit people with properly fit hearing aids in the early years. And then as their hearing declines and hearing aids are no longer helpful, then those are people that would be cochlear implant candidates, or at least need to come in for an evaluation at a cochlear implant center.
Okay. I have a lot of questions here.
Okay.
How do cochlear implants work?
So let's first start how hearing aids work, because most people know that. So you place a hearing aid in the ear canal, and that acts as an amplifier of the natural pathway. So it vibrates your eardrum, it vibrates the 3 little bones in the middle ear space, and then that signal is translated into an electrical signal in the cochlea of the inner ear, and it runs along the nerve to the brain. So basically, a hearing aid is an amplifier of natural sound.
Okay, wait. When you say the three little bones,
right,
you're talking about tiny. Like, how big are these things?
So these are, millimeters big. They're the smallest bones in our body, the malleus, incus, and stapes. And those are all found in the middle ear space. And a hearing aid just amplifies the natural hearing pathway. But
because those bones need what happens? Do the bones get, why aren't they capturing sound and processing sound as well as they were?
So the little bones, by and large, there are disease pathways that affect those little bones. But the vast majority of hearing loss is not affecting the little bones in the middle ear. It's the inner ear hair cells of the cochlea or the neurons of the cochlear nerve that are affected. And what a cochlear implant does is it bypasses the conductive components, and the electrode is placed directly into the cochlea, stimulating a new pathway, basically stimulating the cochlear nerves directly. So it's bypassing the ear canal, it's bypassing the eardrum, it's bypassing the three little bones in the middle ear space, and the electrode is placed surgically into the cochlea and stimulates the cochlear nerves directly.
Wow. So it acts as a new apparatus for those things you just described.
Right.
Okay.
And it's a very safe surgery. It's about 2 hours long. It's an outpatient procedure. A lot of my time is spent with patients explaining the surgery and explaining how, a lot of patients say, well, I came in for hearing aids and now here we are talking about a surgery. And that's very scary to patients. But when I spend time explaining, that it's a very small incision behind the ear and that it's about a 2 hour long procedure, it's a same day surgery. You come in the same day, go home the same day. And then you're activated in about 1 to 2 weeks and we get you off and going.
Okay. So how big is the cochlea?
So the cochlea it's an interesting shape. So it's sort of like a snail shell. It has 2.5 turns. It's very small. It's millimeters small. And the electrodes are even smaller in diameter. And it's exciting that we can place an electrode that has many different frequencies and can stimulate the hearing apparatus in a tonotopic map. And the idea is that the processor brings the signal in, that that signal is translated into electrical information, and that selectively stimulates certain nerve populations to recapitulate what sound is like in the environment. And so it's really a miracle in medicine that we can.
Yeah. So how do you go in and operate and implant something so small into something else that's so small? Right? You're not going in there. I mean, what do you use to do this?
So, it's sort of the same techniques as neurosurgeons use. I use a microscope so that I can, and very delicate instruments. I use a tiny little, we call it an otologic drill. So it's like I use a drill that has very, very tiny millimeter sized drill bits. And I'm able to drill the anatomy so that I can approach the cochlea, make a tiny little fenestration or hole into the cochlea, and then thread the electrode.
Okay, so I want to talk. Otologic drill is my favorite term so far. Okay. Now, are you using that to go through the skull or something else?
Yeah, so I don't want to scare the listeners of your podcast.
No, we won't.
But so I put the patient to sleep with my anesthesiology colleagues. It's a general anesthesia usually, so a person has the breathing tube. I then make a little incision, a few inches long behind the ear. And then I place the internal device in a pocket. So I create a little pocket under the temporalis muscle, which is the chewing muscle, and that will hold the internal device.
And how big is that?
That's a few inches long. Is it
really flat though, or what?
The profile has gotten flatter and flatter over time. Sure. In a person with a thin skull, you'll be able to feel the edges. In a normal man with your sort of profile, you wouldn't feel it at all under the chewing muscle there.
Okay, so that's that, and then what?
So then I'll take that little otologic drill that is your favorite word, and I do drill what's called the mastoid bone, which is part of the skull here. It's a honeycomb type bone that its purpose is to protect the skull if you have, or the brain if you have a side impact. So I need to drill that bone in order to approach the cochlea, which is deep in the temporal skull bone there.
And then are you running wires through there?
So I'll create a pathway by drilling. I'll create a pathway to the cochlea, and then I will place the electrode into the cochlea, and then I'll hold the electrode there with some soft tissue, and then close everything up, close the incision up. And then that will heal for about 1 to 2 weeks. And then my cochlear implant audiologist, Becky Lewis, here at Pacific Neuroscience Institute, will turn on or activate the device. And those are really special appointments.
Is it? I bet. So
yeah,
tell us about that.
So, I've started to implant children as young as 5 months, and that is really special. You really see this is a child that hasn't heard any sound in their environment their whole life. And in a 5-month-old, they're not able to have very good head control yet. But when you see their eyes light up and looking around, it really does bring tears to your eyes. Every time I go in the appointment, I say, "Okay, don't cry," and then it's really hard not to cry.
Because you literally see this child's face light up,
right?
And they're getting sound for.
Sometimes they cry because it's scary, because they don't know what's going on. But it's also very moving in an older person that, has lost the connection to their family members, has been completely isolated from social events. And, I have several patients, it's very moving, that were very outgoing and gregarious in their younger years. And when you turn that implant on, it also brings tears to their eyes because they can now start hearing sound, and it's very moving. So although I cannot join in on all the activation appointments, I oftentimes get videos from my audiologist, and it's very moving.
Oh, you absolutely should. I mean, that's the huge payoff, right?
Well, I got to see all the other patients.
Well, that's true. Yeah. I talked to one of your colleagues about relieving pain in facial nerve pain. And he was saying that's a similar thing where one surgery is just a game changer, right? Like you go in with this terrible pain, you come out and it's gone. Or very soon after, right? It's like people are like, "Oh my God, that was a miracle." I can imagine. I mean, really, it is a miracle. Hearing is a miracle. The structure of hearing is a miracle. And to be able to restore that. And now a message from our sponsor. The Think Neuro podcast is brought to you by Pacific Neuroscience Institute Foundation, a nonprofit 501c3 organization. If you're inspired by what you hear and wish to support our mission of education through innovation, please visit pacificneuro.org/foundation.
So Helen Keller, someone asked Helen Keller, would you rather be blind or deaf? Which one is worse for you? And she had a very interesting quote. She said that my blindness separates me from the world, but my hearing loss or my deafness separates me from people. And I thought that is really profound. And so when you take someone's hearing away from them, it really does separate them from people. It separates them from communication. It separates them from music. It separates them from sound. And we're now learning that all of that, social isolation, depression, withdrawal, all also acts and contributes to cognitive decline over time. Absolutely. And so the sooner that we can intervene with folks, especially our older folks, our middle-aged folks and our older folks, the better we'll do for improving hearing health. And we know that hearing health is such an important part of brain health now. Yep. And that's really important in the Pacific Neuroscience Institute umbrella. We all have a mission for brain health here at PNI. And that's my contribution to brain health in PNI. Well,
you just described my mother before she died at 96. She's, Sicilian, family came from Sicily. She's lives for conversation, right? That was her whole life. And she loved nothing more than to talk to friends and family. And when she started losing hearing, boy, oh boy.
Yeah.
That was a big deal. And fortunately, hearing aids, kind of came to the rescue. Yeah. And it gave her, a new lease on that. But yeah, connecting to people. I mean, that really resonates with hearing, right? Wow. So how many of these can you do in a week?
Well, so I usually do about 3 a week. And the really important thing is that we need to be doing more. So there's a scary statistic out there that only 5 to 7% of people in the United States who qualify and would benefit for a cochlear implant actually receive one. And that's one of the reasons I'm doing this podcast, is for public education. That needle really has not changed in decades. And one of the reasons I came to PNI is really to start a community-based cochlear implant program for children and adults, to really reach, to educate primary care providers, to educate other physicians, when to refer patients, to educate community audiologists, when to refer patients, and then to educate the public. And that's where what we're doing here with this podcast is trying to reach as many people to say, hey, if you are a person that has properly fit hearing aids and you're still struggling, meaning I don't like going to events, I don't like talking on the telephone, I can't understand, I'm really struggling, even in quiet environments, I'm having a hard time understanding, you need a cochlear implant evaluation. It doesn't mean you're a candidate, but it means we need to look into whether you would benefit from a cochlear implant. We all have that Aunt Sally who has 6 pairs of hearing aids and they're all in a drawer. She doesn't want to talk about it anymore, and she's frustrated. We all have the Aunt Sally. You don't think Aunt Sally wants to hear? She's frustrated because the hearing aids aren't working for her.
And we went through that. We went through that with my mom. Exactly that.
Yeah.
She was like, these things are great, but God, they pick up noise here and there. And, I think if she'd been younger, it would have been cochlear implant time, right. And it would have been amazing.
The audiologists and primary care providers worry that they don't know who to send and the criteria of who to send. And I tell folks, just send people. If they're not doing well, we can tease out, okay, who's a good candidate and who's not. But it's better to send people early than to not send them at all.
Is this a case where, like so many electronic devices, because, of Moore's law and processing power, has this technology gotten any cheaper over time?
So the answer is yes, but they're still very expensive. But the good news is that commercial insurance and Medicare will pay for this surgery.
So it has good coverage under Medicare.
Yes, we're still working on, now we're really pushing every year we push the candidacy criteria, meaning, back in the day, you had to be profoundly hard of hearing in both ears. Now we're even implanting people who have normal hearing on one side and no hearing on the other. We call that single-sided deafness or single-sided profound hearing loss. So before, that person would not be considered a candidate. They'd say, well, they have one good ear. That's good enough. But now we know, if you had one bad eye, would that be good enough? No, we would try to help the eye. And so now we're implanting people with single-sided deafness are doing very well, both children and adults. And so now we're pushing insurance to cover that indication as well. Most commercial insurance will cover that indication. We're still working on Medicaid or Medicare for the single-sided.
Interesting.
But they'll come along soon on that. But for run-of-the-mill, both sides having trouble, commercial insurance and Medicare will pay for it.
That's terrific. What should people be doing? Say, somebody like me in his 50s wants to keep on hearing things. What should I be doing to preserve my hearing? What should I not be doing?
Great. Well, we can't help the genetics that we inherited, right? We can't help our which family that we joined on this earth, but we can help what we do with the hearing that we have. So noise exposure is the number one thing that we can control in our environment. So I tell my patients, I do this. I carry earplugs in my purses and my jackets. I carry enough for my family, for my friends that are joining us at events.
Mm-hmm.
Our society is just too loud. Weddings, places of worship, restaurants, movie theaters, for God's sake.
Cities.
City, all of this. So, and for my patients that are really tech savvy, I tell them, there are free apps that you have on your phone. You can just go to the app stores and put in decibel reader. And
I have one.
Yes.
I have one.
And you can put this on and it'll tell you the actual decibel reading and when it's becoming hazardous to your hearing. And that's a time to put in your earplugs.
When you get to what level? I mean, is it when it's on in the red in my little
in the
app,
red in the red? Level. Yeah. And our bodies, you can feel when things are too loud. You can feel when things are too loud. Our ears hurt a little bit. That's your body's way of saying, get out of this noisy environment. But we tend to just push on music concerts and all of that. And so we want to make sure, certainly if you're using firearms, you need double ear protection at all times, firecrackers, but mostly it's music and music concerts and loud, noisy environments. And then another thing are ear pods. So I tell folks, please be very careful with ear pods. That's a direct noise exposure directly into the ear canal. You need to continue to turn the sound down. Also, before you put the ear pod in, you really should turn on whatever music or noise that you're hearing. I've had quite a few patients that put the ear pods in and then turned on their phone and either their children or something in their bag, put the volume up, and they had, a very loud noise exposure that caused damage. So noise exposure is the number one. And then, going down the list, we can't help when we get infections, and we can't often help, what medications we need, or chemotherapy drugs are a big cause of hearing loss. And a lot of times we can't help that. But what we can—
Why is that? Just briefly, why is that? Is it just—
A lot of chemotherapy drugs are what we call ototoxic, meaning they really are toxic to the little hair cells of the inner ear. And, oftentimes we don't have a choice. We're fighting a terrible cancer and an ovarian cancer or breast cancer. But I work closely with the oncologist to do our best to try to protect the hearing. So we'll do hearing tests before the chemotherapy and oftentimes monitoring during the physical therapy or during the the chemotherapy, and if we're able to give some steroids to try to prevent the ototoxicity. But that's another area of research in our field, is how do we protect against the ototoxic effects of some of the chemotherapy drugs.
Yeah, fascinating, because those hairs are just so delicate.
Right.
Yeah. So those are some great, that's some great advice. Have you seen this research about how persistent noise, especially in cities with cars and loud noises, is having all these other health effects? It was a piece in the New Yorker about this, where they were linking just incessant loud noise to things you wouldn't even think of being related. Like, I can't remember what the diseases were, but I want to say it was, maybe it was diabetes. It was something like that. And it really alarmed me, because I live here in Portland, Oregon, and it seems like everybody here has got a loud car that's made purposely loud, and cities are just loud as a rule, right? And it just seems to me that one thing we should do as a society is try to regulate that a little bit. It's unpleasant, but it also turns out to be unhealthy if this research is correct.
Right. Yeah. And, that's why just being aware of your environment and trying to, we can't change society overnight. We can't change environments over, government can only regulate so much. But what you can do as a private patient is, get your decibel reader, make sure you're being responsible with the environments that you put yourself in.
Yeah. I wish I'd talked to you 35 years ago, before I went to that, Pretenders concert in the second row.
Here in Los Angeles, we have a lot of people in the entertainment and music industry. Yeah. And that's another part of my job, is really getting awareness out into the entertainment industry and making sure that the musicians are coming in right away to get baseline screening. And we even have musician earplugs. So the audiologist will make custom molded earplugs. Yeah. I'm sure you've seen a lot of high profile musicians wearing custom earplugs, but they let in certain decibel ranges and frequencies so that they can still blend and harmonize the sounds. And so that's really important to educate our musicians. If you are a musician, instruments, bands, singing, it's good to get baseline audiograms. And then, noise exposure. I always tell folks in that industry, this is an occupational hazard for you. Just like, a football player has occupational hazards to their other body parts. In the entertainment industry, the ears is an occupational hazard. And so the noise exposure there. And so just to really educate and get those baseline hearing screening tests, and then follow people along and make sure that, every year coming in, rechecking their hearing, making sure we're still okay, and making sure their musician plugs are fitting well, and all of that sort of thing.
Does anybody make sort of something between the earplug that I know, like the little foam things, and the musician earplugs that you're describing for like concert goers?
Yeah, more and more, if people are interested, most audiologists can make custom made, earplugs for you. And also, a lot of our surfers, it's not necessarily for noise exposure, but to keep the water out of the ears. We call them surfers plugs. They'll come in so that they get a really good watertight seal. And that is, so the audiologist can just take a quick mold impression of your personal ear canal and make a plug for you.
Because I have friends who go to a lot of concerts, and I'm going to mention this to them because they're in there with the little foam ones. And I think they'd probably be happier if, these are people who are kind of audiophiles, right? Mm-hmm. So they probably want something a little better in terms of letting sound in. I don't know. But that's fascinating. Okay, last thing. This is so interesting to me. This is a little open-ended. Is there anything that you are kind of seeing in the research or on the horizon in terms of hearing that is exciting to you, or you're kind of watching?
So really the link between hearing loss and cognitive decline is so important. When I go around and I speak to other physician groups, neurologists, primary care doctors, even pediatricians, because they're starting the journey of life, it's very important to know that hearing loss is not only linked to cognitive decline, but by treating hearing loss, we can help pause cognitive decline and even improve cognition. And the early research is just starting to come out about that it's not just an association, that when we treat hearing loss with either hearing aids or cochlear implants, people's cognitive scores go up. So there is a direct correlation of treatment, which as a physician is very exciting. It means as a surgeon, I can intervene. I can help change the course of the neurons in your brain. And that gets back to my original doctorate, is what I'm doing in the clinic can actually change the neurons in your brain. And that's really exciting for me. My grandmother died of Alzheimer's, and if it's a terrible, cognitive decline as we get horrible, it's terrible. And so if we can do anything to help slow down, reverse, improve cognition, this is very exciting research coming up.
Well, and right now we've got this aging population that is dealing with cognitive decline, right?
That's right.
And if we could imagine the savings in health and money and every other thing, if you could offset a fraction of that even, right?
That's right.
So,
that's right. And you can get your Sicilian mother back at it. And
no kidding. Well, listen, I'm going to hang on to your number in about, 20 years.
Anthony, let's get you a baseline audiogram. Let's start there.
I would love to. You know what we should do? We should do that, and then I'll have a podcast about it.
I love it. I would love to help you. And another thing to just mention as we close is, my catchment area of patients is from San Francisco to San Diego and everything in between. And we are working hard at Pacific Neuroscience Institute to see what we can do with telemedicine. There's a lot we can do with telemedicine to get people tested locally, get their audiograms locally, get their imaging, their CT scans and their MRIs locally, get their primary care doctor to medically clear them for anesthesia locally, and then they can just drive down for the surgery. And even another exciting thing is the audiologist, the technology is developing quickly where she can program the cochlear implant remotely in your home, which is really, really, really exciting. And this is going to help our group reach many more people in a vast area. You don't just need to be down the street, but we can help you from afar.
Yeah. And there's so many people in that situation now, right, who are living in rural areas because these centers of excellence are only in so many places.
That's right. That's right. And then even the elderly. So it might be, a rancher in the middle of Northern California, or it may be, Aunt Sally down the street, but she doesn't have a ride to get to the clinic. Yeah. And so if we can set her computer up and, or if she has a grandchild that can help her at home, kind of figure out how to run the computer, and then we can just remote in and get her all programmed.
Oh my gosh. Yeah. That's amazing. Well, I'm really glad you're on the job. Well, let's do this again. There's so much to talk about here, and I'm glad we got the basics and a little more, I think, today. And I think people are going to find this useful.
Well, thank you, Anthony. It's nice talking with you, and thank you for giving me the opportunity. I hope this information reaches a lot of people. And just let us know if we can help you. If you're having trouble with your hearing, give us a call.
Fantastic. Thank you, Dr. Volker.
All right. Bye-bye.